Hello everyone and welcome. In this video, we will be discussing regarding diabetic retinopathy. Now, diabetic retinopathy is a microvascular complication of diabetes mellitus, as we all know, affecting the retinal vasculature, which leads to vision impairment and potential blindness. Clinical features of diabetic retinopathy will depend on the stage that the patient is presenting to you with. So, we will go one by one. First is mild non-proliferative diabetic retinopathy, mild NPDR. In this stage, there are microaneurysms, which are basically the earliest visible sign of retinopathy, with minimal retinal hemorrhages and few hard exudates. Symptoms are usually nil at this time. Most patients are asymptomatic. There might be mild blurring of vision if a concomitant macular edema is present. So management at this stage is basically strict control of blood sugar, blood pressure and lipid, and annual fundus examination at this point is recommended. The next stage is moderate NPDR. In this, number of microaneurysms increases, dot plot hemorrhages increases. You see cotton wool spots, which are basically areas of ischemia. You see venous bleeding, which is dilation and irregularity of the veins that you see, and there are mild intraretinal microvasculature abnormalities, also known as IRMA in short. Usually, patient remains asymptomatic even in this stage. Visual disturbances, if any, are due to macular edema. Management at this stage would be follow up every 6 to 9 months, and aggressive metabolic control is required to slow down the disease progression. If diabetic macular edema is present, then laser treatment might be needed and you should refer the patient to an ophthalmologist. The next stage is severe NPDR. This is also called as pre-proliferative stage. In this stage, there is 4 to 1 rule, that is either severe retinal hemorrhage which is present in 4 quadrants, or venous bleeding which is present in 2 quadrants, or intraretinal microvascular abnormalities present in 1 quadrant. If any of the following is there, the patient is said to have severe NPDR. In this stage, management includes close monitoring every 3 to 4 months has to be done. You should ideally refer this patient to an ophthalmologist, because to prevent progression to PDR, panretinal photocoagulation may be considered early in this stage only, and a very strict metabolic control is required here. Then the next is PDR, which is proliferative diabetic retinopathy. What happens is retina starts responding to the ischemia by neovascularization. Now the new vessels which are formed, they are fragile and they are prone to bleeding. So what we see is, one is NVD, that is neovascularization of the disc. Another thing is NVE, that is neovascularization elsewhere away from the disc. Vitreous hemorrhage can occur, which can actually cause sudden loss of vision. And there is fibrovascular proliferation, which leads to fractional detachment. Symptoms that the patient might have in this stage is there might be presence of floaters or a hazy vision. There might be sudden painless loss of vision if vitreal hemorrhage has occurred. Management in this stage includes panretinal photocoagulation that reduces ischemia and neovascularization. We can give anti-VEGF like bevacizumab, they reduce neovascularization, and vitrectomy surgeries can be done if there is persistent vitreous hemorrhage or if there is fractional retinal detachment. We'll also be discussing regarding diabetic macular edema. Now, diabetic macular edema can occur at any of the stages in diabetic retinopathy. Basically, vascular permeability increases, which leads to fluid accumulation in the macula, and that affects the central vision. Types of diabetic macular edema, it can be focal when there is just localized leakage from a microaneurysm, or it can be diffuse in which there is widespread leakage. Then there is a term known as clinically significant macular edema, which requires urgent treatment. So patient having macular edema over here presents to you with symptoms of blurred or distorted central vision. They might have difficulty in reading or recognizing faces. Management, first line is anti-VEGFs only. Then focal or grid laser photocoagulation can be done. And other than that, intermittent steroids like DEXA implant in refractory cases can be given. A question has been asked in diabetic retinopathy only, asking about the role of family physician in prevention and management of retinopathy. So the points that you can mention in this answer is, first is that as a family physician, you will conduct regular fundoscopic examinations for the patient, and you will also take care of a comprehensive eye evaluation as per the screening guidelines which have been mentioned for early detection of the disease. Then you will take care of strict control of blood sugar, blood pressure levels, lipid levels, so that the disease progression can be slowed down. Another point you can write regarding is educating the patient about importance of good metabolic control, educating about importance of adherence to the management plans, and telling them about the probable risk factors associated with poor control. Another point that can be mentioned is that you will ensure timely interventions as and when needed for the patient by co-managing the patient with an ophthalmologist. And lastly, you can write that as a family physician, you will provide support for lifestyle modification, encouraging the patient to maintain a healthy diet, exercise, cessation of smoking, etc. Now that's it for diabetic retinopathy. In the next video, we will be covering a very short topic regarding ocular complications in diabetes. So please watch that video as well. Thank you so much, and I'll be seeing you in the next video.